the TSH level more than the normal will start to increase the levels of the total cholesterol. And this is due to what? To increased in the level of the cholesterol due to what? Due to a decrease in the number of LDL receptors, less or decrease LDL receptor activity, and decrease in the LDL clearance. This will lead to increase in the total cholesterol, LDL, which is the bad guy, as they call it, and other things. So there is a linear relation and rise between lipid profile and hypothyroidism, the TSH level. The higher the TSH, there will be increase in level of lipids. The effect of hypothyroidism in the renal function. Usually, these patients with hypothyroidism, they have elevation in their serum creatinine, increased 24 hours urine protein, reduction in the serum cystatin C levels, and decreased in the water load. So patients should be treated for this kidney function. Now, what about the GI tract? The very common problem, it can affect from the mouth to the anus, including the esophagus, stomach, intestinal colon, and the liver. This is the GI tract. But most of the time, think about the slowness of the passage of food from the mouth down to the intestine. There will be disturbance in esophageal peristalsis, gastric dysmotility. There will be less gastric emptying, delayed achlorhydria, and there will be most of the time constipation. Remember this, patients mostly they complain of this. In addition, the liver, there is slightly disturbed liver function tests, decreased gluconeogenesis, decreased urea nitrogen production. All these can happen secondary to hypothyroidism effect on the GI tract. What about the menstrual function and fertility? This is common symptom and problem in our female patients. The hypothyroidism will lead in the females to polymenorrhea, anovulation, and infertility. So many they are coming, they want to get pregnant, but they are unable because of this hypothyroidism. In addition, if they become pregnant, they may get preeclampsia. They are exposed to preeclampsia, growth and brain developmental problems in the baby. There will be miscarriage, low birth weight, and stillbirth. These are complications of hypothyroidism on the side of the fetus or the infant. In the males, we have erectile dysfunction, reduced sperm count, reduced sperm quality. The problem of hypothyroidism affecting the females and males, but very important to see that it is very relevant or relevant about 2 to 4% in those with reproductive age group. They want to get pregnant, the ladies. The men, they want to be fertile. They want to, to have no problems with erection. And this might affect the young generation, the reproductive age group. Now, what about the bone and muscles? The hypothyroidism will affect the bone and lead to reduction of osteoblastic induced reabsorption, as well as reduction in osteoblast induced formation. They end up with osteoporosis, with problems, low bone turnover, and it affects the muscles. They come with cramps, myalgia, cramps, stiffness, easy fatigability, as well as maybe if we check them, we see delayed relaxation phase and the deep tendon reflexes when we check them in the clinic. So these are very important symptoms and signs. What about the nervous system? Nervous system is important because the hypothyroidism will lead to myopathy, memory deficit. They start to get memory loss. They don't remember. Depression, anxiety, some psychiatric problem, carpal tunnel syndrome because of the retention of the fluids in those patients with hypothyroidism, compression of the tunnel of the median nerve in the wrist. It will lead to carpal tunnel syndrome, and patients will be, very tired. They cannot make exercise. They have low exercise tolerance. Now, the levothyroxine is the answer. It's the gold standard for treatment. Patients used to ask me in the clinic, Dr. Amin, do you have any replacement, other drug to replace the levothyroxine? I said, no single drug They talk about herbs, about other medicines, about, these days, they talk about too much about this, especially in the social media. And they ask me in the clinic, I say, no replacement at all over earth to have to replace this medicine. So it is this medicine very nice, long serum half-life, which is almost 1 week, good intestinal obstruction, is administration in tablet form, effectively resolve symptoms of hypothyroidism. Patients will start to come to the new life again in a good way. And also, long-term experience of its benefits, favorable side effects. There is no side effects, and it is low cost. So thyroxine is the answer. It's the gold standard for treatment. Now, what about how to manage, how to start, to initiate and monitor the treatment of hypothyroid? Well, for those patients who are above 50 years of age, one should be careful not to give them or start or initiate high dose because we don't want to induce cardiac disease or some infarction. I saw some patients like that. They start with them with 200 microgram from the beginning. Usually start with them, especially those with heart disease. Look for small dose, 25 microgram or 50 microgram for about 2 weeks. And then you can upscalate it and titrate and increase the dose according to the patient need. If the patient is young and no cardiac disease and fit, you can start with higher dose. Now, when a common question, when to check if I start today some thyroxine tablets for my patient, when to check the result. Usually, one should check the thyroid function, the free T4 TSH, within 6 to 8 weeks. I used to do it in my clinic within 4 to 6 weeks. And if the patient is still having higher TSH, one should increase the dose and continue the monitoring and escalating till we reach to the required TSH level in the non-pregnant around 2.5 to 3. Now, what are the factors that influence dosing requirements of levothyroxine? So many. If the patient, female patient, is pregnant, one should think about, higher dose. Aging. What age? The weight. If there is higher weight, usually I say to my patients, if you get more weight, you will need higher dose. Comorbid conditions. If patients is having diabetes or ischemic heart disease, concomitant medications that we are going to talk about, the question that I asked you at the beginning, and the food intake, because food with this tablet will have less absorption for the medicine. So these are factors that may influence the dose requirement of thyroxine for our patient. Here is the levothyroxine and the TSH target for therapy. As I mentioned, we start with 1.6 microgram per kilogram body weight for those uh, people who are doing well and they are young. For the pregnant patients, we start with 2 to 2.4 microgram per kilogram body weight. For the elderly, we have to be careful, smaller dose and to titrate. The patient with ischemic heart disease, lesser dosage, and the patient with enzyme-inducing drugs. These enzyme-inducing drugs, like what we say the phenytoin, the carbamazepine, we have the rifampicin, and maybe phenobarbital. These medicines that will lead to increase breakdown or activity of the enzymes of the liver and making the medicine level is absorption is rapid. That level its level in the blood will become low. So this all will affect the level of treatment with thyroxine. The TSH level, as I mentioned, around 2.5 to 3, and don't go to or over treat because this will make a problem for the patient. Now, what are the causes for appropriate levothyroxine dosage? Why? If we give a medicine like thyroxine with food, the absorption is only of this medicine about 64%, while without food, very high absorption, about 80%. The thyroxine tablet does not like except empty stomach. to be achlorhydria, no pH, to be acidic, and this to be given 30 minutes before breakfast or at bedtime 3 or more hours after evening meal because it doesn't like the food. Why? Because the absorption will be less. With food, absorption is only 64. Almost 15% is absorption less with food. So we try to avoid the food and give it in fasting stomach. Now, these are the diseases or drugs that can affect the absorption of the thyroxine. The disorders, we have the autoimmune gastritis, the bariatric surgery, celiac disease, gastroparesis. All of them, as you see, they are GI problems. The giardia infection, Helicobacter, very common problem, lactose malabsorption, liver cirrhosis, ulcerative colitis, all of these disorders interfere with the absorption of the levothyroxine. The drugs, the more common drugs, the question that I already mentioned before, and you answered it nicely, the drugs like the BBI, commonly used, it affects because it makes acid suppression. The beta blockers, the bile acid sequestrants, different types. The calcium, like carbonate, citrate, acetate, we use it very often in the clinic. The we have the charcoal, the ciprofloxacin, the ferrous sulfate. So many ladies they have iron deficiency anemia. They are on ferrous. I used to say, take your thyroxine in the morning and make this ferrous sulfate in the evening. Try to make a difference because it will affect if you take it at the same time. It will affect the absorption. We have other drugs like the multivitamins, the oral bisphosphonates, Orestat, Genical is one of the drugs that interfere with the levothyroxine absorption. We have rifampicin, raloxifene, simethicone for the irritable bowel, the antidepressants. These are the ones that can interfere. So many. In addition to the food, if you have taken the female patient or the sick hypothyroid patient, take it with coffee, with fiber, grapefruit, ingestion with a meal, papaya, soya beans, and soy. This all will affect the absorption of the levothyroxine. So one should be careful. This is just to remind you about some of the conditions that lead to high TSH levels, like those with higher obesity or morbid obesity, advancing age, female gender, calcium, iron, iodine supplements, dietary soya, we mentioned already. This can lead to higher levels of TSH. We remember that some drugs that can lead to both high levels of TSH and low levels. Amidrone, very commonly used in the cardiology patient and cardiac patients. Lithium, the diurnal and circadian variation makes the difference in the TSH level. We have some endocrine disruptors as other endocrine diseases. Some of the drugs that lead to lower TSH, like metformin, during pregnancy, we need higher levels, higher dosages to control the high TSH, and so on. We don't forget the BBI, the interferon, which commonly used, the dopamine agonists. All these can affect the TSH level, whether low or high. Now, what about biotin? Biotin these days is used by so many patients. Female patients love this biotin, and it is a supplement. And they sold it as a vitamin B6 under this name, like B6, vitamin H, coenzyme R, whatever. Biotin will lead to a picture of hyperthyroidism by the lab test. So it suggests there is hyperthyroidism, but it is not that the patient does not have the signs or symptoms of hyperthyroidism. It just make higher levels of thyroid hormone, the biochemical test. And if I want to check the high thyroid hormone for level for somebody or lay patient taking biotin, I have to ask him to stop it or ask her to stop it for 1 week and then will to remove the effect of biotin that lead to hyperthyroidism. And everything will be back to normal after stopping it. Now, this is just a report from our colleagues showing that the interference of pharmacologic biotin levels in hormone immunoassays has been previously described in a few case reports. This is different in a patient here in 2016 down to 2012. They have different case reports. Patients were taking biotin and it showed that there is interference. The TSH was suppressed and the elevation in the free T4 and total T3, a picture of hyperthyroidism. So somebody on biotin, don't do the blood test unless stop for about few days, like a week. Now, what about thyroxine use during Ramadan? This is my aim and target for this meeting. We know that Ramadan is one of the five pillars of Islam, and it is everybody who is Muslim uh, should, fast. And we have the fasting about 30 days. It is one whole month. It starts from the dawn to the sunset. No food, no oral intake, no water, no medications, and the altered fasting patterns were suhoor is the pre-dawn meal, iftar is the sunset meal, breaking the fast, and then to create a new medication timing because of the food interference, especially with thyroxine, because thyroxine absorption with the food is impaired. Now, some people they said we don't take the medicine during Ramadan while we are fasting and so on. What about the optimal fasting absorption? 70 to 80% on an empty stomach, the absorption of levothyroxine. It should be given 30 to 60 minutes before food intake. And this absorption is reduced in non-fasting. About 59 to 68% of the levothyroxine will be absorbed if there is food in the stomach. So better to take it fasting, as I already mentioned. And the TSH elevation during Ramadan, there will be increased TSH about 1.8 to 3.07. This has been shown in the different studies because of the interference of the food taking the medicine with it during fasting in Ramadan. This is just some of studies show the interest to know what is going in Ramadan, which is the best time, the proper time to take the levothyroxine. As you see here, the South Asia Guidelines for Management of Endocrine Disorders in Ramadan mentioned, and here their conclusion. Although there are essentially no data of adjustment of treatment protocols for patients with thyroid diseases, they propose that hypothyroid patients can take their thyroxine at bedtime easily instead of half hour before suhoor. For sure, for the hyperthyroidism, at any time you can take the medicine of methimazole, carbimazole, whatever. But for hypothyroidism, they think, these people, South Asia, that to take it at bedtime easy instead of half an hour before suhoor. Now, in 2021, the European Thyroid Journal, our colleagues from Abu Dhabi, they made a prospective randomized controlled trial when to administer the levothyroxine in Ramadan. And what did they find? The conclusion was that their data suggests instructing patients to take levothyroxine at the time of breaking the fast 30 minutes before the iftar minimizes unfavorable changes in plasma TSH post-Ramadan. They think that 30 minutes before iftar is better. For me, I don't think it is logic that I will take a tablet and then I will wait for another 30 minutes and other people are taking the breakfast and I am waiting. Most of the patients, they will not wait, maybe 10 to 15 minutes and they will start taking the food. I don't know. I don't advise my patients to take it 30 minutes before iftar because people are fasting, they are having their food, they're breaking their fast, and maybe after that they are praying while you are waiting for 30 minutes not taking your food. This is another study which is a recent one in 2023 June, they see this is a review article, and they found that effect of Ramadan fasting on thyroid function in hypothyroid patients taking levothyroxine. Systemic review and meta-analysis. What is their conclusion? TSH increases significantly after Ramadan. No timing point has superiority in maintaining thyroid control. However, choosing the timing should be individualized according to the patient's preference to guarantee the most benefit. This conclusion made it open that whatever you want to do according to the patient and possible complaints to do it. Iftar, suhoor, bedtime, whatever. Coming to the last one, which is I think this is in October 2024, a very recent one from Emirates as well, Al Qasim Hospital. They made a study showing that extra levothyroxine dose in Ramadan maintained normal thyroid hormone levels in patients with hypothyroidism. This is a randomized controlled trial, and the conclusion was that if the extra dose of levothyroxine given, it showed it had positive effect on keeping the TSH level in patients with normal in the normal range. So they advise to give an extra dose of levothyroxine in Ramadan. Now, this study that showed three options. This is from Saudi Arabia, a recent one from Professor Ali Zahrani from Mahzari, as well as Dr. Kubesi. So many studies they did, and they found that pre-iftar timing is good, 30 to 60 minutes before breaking the fast. Pre-suhoor, 30 to 6 minutes before suhoor, and at bedtime, 2 to 3 hours after iftar, because the stomach will be empty after iftar. At bedtime, or midnight, they can take the medicine and they should, there is no problem. So these are the options that given by the studies from Saudi Arabia. And the comprehensive management strategy in Ramadan, not to think about it during Ramadan only. One should prepare the patients, as Professor Hassanin mentioned, how to manage diabetes, not only at the time of fasting, but before Ramadan to prepare our patients. And before Ramadan, one should check the level of the thyroxine, the thyroid hormone, and to make sure that it is okay. If not, to adjust it and to replace it. During the Ramadan, one should look for the pre-iftar, bedtime, or pre-suhoor as three options can be given the thyroxine, but make sure 30 to 60 minutes, no food. And the post-Ramadan, one thing after Ramadan to check the thyroid function, never do it immediately after Ramadan. No, we have to recheck it within 2 months after Ramadan because there will be changes. Now, coming back to our question, as you mentioned, the time for hypothyroid patient to take the levothyroxine during fasting in Ramadan, I think the answer is to take it at suhoor in empty stomach, at least 30 to 60 minutes before eating, or we can, uh, uh, or anyway, we have to make the poll again and see if there is change in the mind. Let us see which one. Which answer, my colleagues, you think that it is the best time after this talk to take the medicine thyroxine during fasting Ramadan? There is an improvement. 62%. The answer C and E, which is the right answer, and the others little bit less. So it is right that the patient can take it on empty stomach at least 30 to 60 minutes before eating, or in the middle of the night, 3 to 4 hours after the last meal on an empty stomach. The next question, what drugs affect the absorption of levothyroxine? What do you think? Oh, great. 72% saying all of the above. That's right. all medicines that mentioned here, antidepressant, PPI, ferrous sulfate, biotin, estrogens, they can interfere with the absorption of levothyroxine. Thank you. I think this is the last. And Ramadan Mubarak, inshallah. And thanks for your attendance. And please, if there is any question, Dr. Rafat, Professor Hassanin, to join me and to help me.
Very comprehensive cover for thyroid problems out of Ramadan and during Ramadan. Thank you very much, Dr. Amin. Very interesting presentation. In fact, most of the questions are for thyroid. I think only the first question is about Ramadan and diabetes. So perhaps let me take this one on insulin correction dose during fasting period. Thank you for the person who asked the question. It depends obviously on which type of insulin, whether it's basal insulin and once a day or twice a day, and whether it's mixed insulin or basal bolus. So let's go through it gradually. Ultra-long-acting insulin, such as degludec and glargine 300, you don't need to change the timing. The others, you give them at iftar. For both, you need to reduce the dose if the person is well controlled. But someone who's poorly controlled, no need to reduce the dose. If someone on mixed insulin, the big dose at iftar and the smaller dose at suhoor, and that suhoor dose need to be reduced by about 25 to 50%, depending on how tightly they're controlled and about the nature of their job. Then we come to the prandial insulin. The iftar time adjust the dose up and down according to the size of the carbs in the meal. Do the same for suhoor, but take into account that the person afterwards is fasting. So still reduce the suhoor dose a bit rather than give the same dose. If the person is going to have a sizable snack or a small meal at 11, at midnight or whatever before they go to bed, then they can take a third injection as well. So that covers really the different types of insulin and the timing for them. So, Dr. Amin, it looks like
Yes,
people really were
there's a
keen
question.
on the, on the thyroid part.
Yeah. How
Can you see the
often
questions?
how often should we do thyroid function test once TSH has established with a particular levothyroxine dose? Well, we check the thyroid hormones every 3 to 4 months, usually. And for Ramadan, we check it before Ramadan and 2 months after Ramadan, or if the patient is having symptoms of hypothyroidism. The other question, when to do it, fasting or without fasting. We don't need to fast patient to do thyroid function test. Can do it fasting and can do it without fasting. The only
I mean,
tests.
I know that some colleagues advise their patients to do the blood test before they take the thyroxine dose. I don't think it have a strong impact. I agree with you, Dr. Amin. It's probably tiny amount of change that can happen with the simple ingestion of half an hour before the blood test or whatever.
Sure. Patients are asking a very common question that Professor Hussein reminded me about. That should, doctor, I didn't take my tablet today. Can I do the test? Not about the food. They are asking about the tablet that day of doing the blood test. She didn't take. I said, no problem, because this half-life is 1 week.
Exactly.
Patients can forget their medicine for 1 to 2 days, even to few days, because the level of the half-life is about 7 days. After 7 days, it will start show the deficiency. Is there a relation between the use of contraceptive pills and thyroid nodule or thyroid cancer? There has nothing to do with that. No, no. What do you think,
No, I agree.
Professor
There's
Hassan?
no correlation, no
Nothing.
correlation at all.
No,
The estrogen
no.
or contraceptive pill, whether they combined or whatever, had no correlation with thyroid nodule or thyroid cancer.
Yeah, the best time of GLP-1 agonist during Ramadan.
I can
Everybody is
at iftar, if they
okay.
are weekly, take it at the normal time when they take it. It doesn't really matter. What would be helpful is to try to avoid excessive fatty and spicy food to minimize the nausea and the GIT side effects.
And not to start it with Ramadan.
Yes.
Yeah.
Yeah.
Can we give the total dose as once per week or distribute it into twice in a week to make it more fun and better adherence? Yes, yes, they can. They can take it as if they can take it and the total dose divided in twice a week, it's okay. The total dose should be there, and then to check and see the problem that what we are doing, that patients, sometimes they are missing, sometimes they are having the weight gain, sometimes they have other medicines and doctors they are not asking about, like what we mentioned already, the antidepressants, the BBI, all these, this will affect the level of the thyroid hormone. It's not only the tablet of the thyroid hormone, other things you have to look for. Yeah. Apart from Ramadan, is it possible to give an extra thyroxine dose to overcome the food effect on absorption? Could be. There is nothing scientifically done, but these people that mentioned it, they did it in Ramadan as a study, and it could help. But I think the best thing to keep the thyroxine dose without related to the level of the TSH, not to connect it to other things. Increase weight, will you have increased demand of thyroxine? The presence of other drugs will increase the demand. Taking it with food, make it increase demand, so on. Dr.
Yes,
Hassanin,
especially that obviously in Ramadan that the window is small, but in normal days, you wanted to take breakfast in the morning and then go to work, then have it 3 hours after taking your tablet. The opportunity, there is plenty of opportunities during the day. The fact once 3 hours have passed with no food, they are suitable to take a thyroxine tablet.
thanks for
The,
Dr. Rabia Sada. She is thanking us for amazing and comprehensive presentation. A recent study found that thyroxine can be given with food, but with a sharp increase in the dose. What do you say? I don't think this is scientific. I don't know about this in real world. No. Let us do it like the way that we mentioned it. Dr. Sahar, thank you so much for this important presentation. What's your experience of using risperidone thyroxine receptor stimulant analog? People are using it, but not we do it here. No. I think this is only pharmaceutical, uh, thing. Not no, we don't use the analogs. No, we use mainly the levothyroxine by name, and not the analog.
there's a question here about someone admitted to hospital with an HbA1c of 13.5, admitted with acute ischemic stroke, and started treatment on insulin. He wanted to fast Ramadan. CKD stage 2, no screen for eyes. This is a person that we need to tell them that you have unstable cardio or macrovascular disease. This is very high risk. And inshallah, in few weeks' time, in few months' time, he would be stable and he would be able to compensate for these days. Allah subhanahu wa ta'ala, when the Quran says, عِدَّةٌ مِّنْ أَيَّامٌ أُخَرٍ, which means they would be able to compensate for this in future days. So certainly this person needs to be advised in the nicest possible strict way that you are a very high risk, because the potential of an ischemic stroke to be higher with the dehydration, with the instability, with all of the other stress factors that could be facing the problem, should not put himself into jeopardy.
Another question, what could be the possibility of high TSH if the patient had good compliance and taking thyroxine 1 hour before food? Taking consideration that patient was controlled for years on the same dose, I don't think there is any problem. This is an excellent patient, good results, and continue the same and just observe and follow up.
I think they're
That
asking on what would be the explanation.
If he is compliant, as he mentioned, at good compliance, means that there is no changes in the weight, there is no problem with other medicines he is taking. He didn't mention, but it is that this patient is having it controlled. He is compliant.
Yeah. I mean, people change, maybe physiological needs, maybe the tablets not being stored in their best way. Uh, at the end of the day, we are human beings, we are not machines. So a slight change, as long as the person is adherent, then a slight modification in those would sort the problem. Another anonymous attendee is thanking both of us for the presentation and asking about explaining the SMBG protocol during Ramadan. Okay, so
There a question for you, Professor.
yes. So we say that the frequency of the SMBG depends on the type of therapy, but obviously it would reflect on other factors as well. So the minimum daily frequency is one a day for those who are on drugs that cause no or min or rare hypoglycemia. If they are on basal insulin or sulfonylurea, then we need a minimum of two. If they're on once daily mixed insulin, they need a minimum of three. If they are on twice daily mixed insulin or basal bolus, they need a minimum of four. Now, this is, of course, the ideal scenario. Some people prefer to go for CGM, and the CGM would be even better and would give them a score of minus 0.5. Choosing the timing would depend on the type of insulin, but the critical time is the between Asr and Maghrib, where the risk of hypo is highest. Another question for me is asking about the relation between HbA1c and hypoglycemic events. Yes, I've shown you a recent study that we've just published a month ago, where we looked into the comparisons of three categories of HbA1c: below 7.5, between 7.5 and 9, and above 9. The classic that people think of is that hyperglycemia will protect them against hypoglycemia. And what we saw and what we teach every day is that's not necessarily the case. And indeed, in the study, that was not necessarily the case. People with high HbA1c had more frequent hypos that was serious enough to make them break the fast, and even higher rates of severe hypo requiring ER admission or hospital admission. So the HbA1c being high was not protective against hypoglycemic events. How to increase awareness for diabetes patients for Ramadan fasting risk assessment? Well, there's lots of ways. Discuss with them in clinic, advertise for awareness campaigns, do awareness campaigns in your community, in your hospital, in big employment places, online, digitally. There is lots of, go to the TV or radio shows that can talk about Ramadan. As long as we are discussing with them a comprehensive process. And of course, the risk assessment is the simple message: can I fast or not? And the beauty about the risk calculator, it unifies the opinion. So if the same patient go to Dr. Amin in Qatar today, and then next week come for a second opinion in Dubai, we applying the same risk calculator, then we will give the same advice rather than different advice. Next question is for you, Dr. Amin.
If the TSH is high, 7, and the T4 17 normal, do you have to increase the dose of levothyroxine? If this patient is having hypothyroidism and levothyroxine taking, the TSH is a little bit high. The target should be around 2.5 to 3 in non-pregnant. In pregnant, should be in the first 3 months almost 2.5, in the second trimester 3, and in the third trimester 3.5. So this one I would increase 50 microgram dose once a week for the dose that is already taking. The next question: any role of cortisol medication in high anti-TPO during pregnancy? There's nothing to do with it. we don't treat anti-TBO. You know what is TBO? TBO is the thyroxine peroxidase antibodies, which means that this patient has a an inflammation or autoimmune inflammation at one time, and this is becoming positive. And this importance to follow the TSH level, not to have hypothyroidism in the future. That's all. If the patient missed 1 or 2 doses of thyroxine, is it possible to take double dose next time? Yes. Today I forget my thyroxine tablet. Tomorrow I can take the one I missed and the tomorrow dose. Yep.
The question about GLP-1 for obesity and not for diabetes. No need to change the dose. They can take it at the same time they used to take it, and no need to change the dose. No risk of hypoglycemia, specifically in a person without diabetes. So I'm not too concerned about this. If a patient has high blood sugar before breaking his fast, so he could taking iftar with same daily insulin and control and checking for for 3 days, or should increase the dose directly as he should have blood sugar. Well, we normally advise not to make a decision on daily basis, or if you want to make the decision on daily basis, then the increment is small. There are two ways of, forget even about Ramadan, changes in basal insulin. You either do it daily with 1 unit or half a unit, if you can have insulins with half units, or every 3 days, where you take the average and look into the comprehensive approach. I personally prefer the decision to be based on every 3 days to have more information. And then another question, so
The
continuous
insulin
delivery
pump,
of it
insulin pump, delivery of insulin in subcutaneous
with
tissue
an
with an
insulin
insulin
pump
pump
does not
doesn't.
no insulin nullify the fasting, neither subcutaneous or intramuscular or intravenous. But obviously we don't give insulin intramuscular or intravenous nowadays. Yes, you can give insulin intravenous in cases of emergencies, intramuscular in the past, or if you have no venous access. That's something we used to treat DKA with when I was a young doctor, but now infusions have replaced this. So what breaks the fast is through the guts, oral or rectal.
Geriatric.
Geriatric population and A1C levels. How about A1C level and its correlation with hypoglycemia in geriatric patients? Thank you. Well, of course, the word geriatric doesn't really correlate exactly with just age. It's more of the frailty of the person. And that's why in the calculator, you saw a new section that talks about frailty and mental function. And the last point is age above 70 and living alone. But hey, there is plenty of people above 70 or far much healthier than me. And I'm not, and I'm in my early 60s. So we have to put a number, but you need to look into the health of the person. Does age affect the target and or the hypoglycemia? Yes, if the person is frail and had long duration of diabetes and their health is not good. But I know many people in their 70s, they are active in sports, active in life. So address every case on its own merits. What are your thoughts, Dr. Amin, on this point?
Yeah, thank you very much, Doctor. This is from Dr. Mervat for your excellent lecture. My question, if asymptomatic patient is having suboptimal level of TSH of about 0.3 with normal T3, T4, should I do any intervention? This is the what is called subclinical hyperthyroidism. Hyperthyroidism, like 0.3, 0.2, 0.1, 0.4 TSH, we don't do anything. We just repeat it in 2 to 3 months. And 50% of these people will become normal. 25% of these people will keep the same, subclinically suppressed 0.3, the same, or 25% will change and go into the so-called suppressed suppressed TSH, which is 0.09, 0.01, 0.02, 0.03. This one is clinically suppressed. We have to know what is the reason. Is it Graves or it is Hashimoto's or thyroiditis? And we know how to differentiate between the two. So point 3, point 2, point 1, don't do anything. Subclinical hyperthyroid, just do it 2, 3 months again and look for the results as I already mentioned. Fatima Al-Kindi, many thanks. She
Yes, Dr.
says,
Kindi, if I know, if I'm guessing, I think I know Dr. Kindi. I think she's a nephrologist, but I'm not certain if it's the same Dr. Kindi or not. But anyhow, Dr. Fatma, um, it's too soon, it's too close now to have a prospective trial. However, retrospective trials are a possibility. After Ramadan is over, think of an area that has questions that are unanswered. And to be honest with you, there's a lot in Ramadan that is not answered. So, for example, let's say that I'm interested in diabetes and the kidney problems. Let's see the rates of fasting and the outcomes of fasting according to the EGFR. Those with EGFR above 60, stage 3A, stage 3B, or even lower, so that we can come to a more comprehensive idea in relation to the actual level of the kidney function rather than simply abnormal kidney function, which what we had in the past. That's one area, but there is plenty of other areas as well. Um, I think we've reached our final question. Clearly, the amount of questions we had reflects the interest of the attendees on these two important topics, management of diabetes and management of thyroid problems during the month of Ramadan, specifically thyroxine treatment during the month of Ramadan, and certainly the variety of issues. Dr.
one
Amin,
question, can we give bioglutamine in female patients for 40-year-old? Yes, we can give, no problem. Sayyid Muhyiddin, thanks for your
any
question.
points to add, Dr. Amin?
I think I got to learn so many things about fasting and Ramadan, honestly, because it is coming so short, and uh, the human being forget. And thank you very much, Professor Hassanin, reminding me about how to manage the tablets, the type of injections of insulin, and when to check, how to check, how to avoid hypoglycemia, who can, and how to follow those who are fasting Ramadan with diabetes. Thank you very much.
Thank you, Dr. Amin, as well for your comprehensive cover of the thyroid problem during Ramadan. It's an area with lots of controversy and
Yeah.
certainly in need for larger research. But at least I'm sure people have understood how to the options that they have during the month of Ramadan. What is an empty stomach? What are the drug interactions of food or different other drugs? Thank you. Thank for our sponsors, and thank you for the choice and Rafat for their excellent execution of this webinar.
Thank you,
Um,
man.
Now,
Thank you all.
finally, please scan the QR code to give us your feedback. It's really very important for us to get your feedback. That always helps to make future educational activities better and better. So with this, I leave you and thank you again and have a good night. Ramadan
Thank
Kareem.
you very much. Thank you. Ramadan Mubarak, inshallah. Shukran.